question from the audience. How much does treatment with bispecific antibodies cost? Is treatment available everywhere, or will I have to travel? And this is a great question. So the price is going to depend on a lot of things, but they're expensive. Okay. But insurances, at least in my practice, have been paying for it if it's approved and indicated. So if we're using it on label, most insurance companies will approve it. And I haven't had any of my personal patients had to have a huge out-of-pocket cost. I don't know if anyone of my colleagues has had that scenario. So yeah, everyone's shaking their head no. So I wouldn't worry about that. Okay. Your insurance has to worry about it, but you got insurance hopefully, and they're taking care of it. So is treatment available everywhere, or will I have to travel? So these right now, and please correct me if I'm wrong, most of these therapies are given at larger academic centers. I know at least in San Diego, our community practices are just starting or haven't yet. They're trying to get them going, but there is some infrastructure that needs to be in place for these therapies due to the side effects that are the cytokine release and the neurologic toxicity, although much more unusual with these than with CAR Ts. But there is a big infrastructure that needs to be in place. And we're spoiled at academic centers. We usually have transplant programs and nurse coordinators that can already absorb this infrastructure. So your local community practice probably does not, and you would then have to travel. And these drugs are given, depending on the indication, every week to 2 weeks to 3 weeks for quite some time. And that would be a travel. Do you guys have any experience where you guys practice with community giving these drugs yet, or no?
So I would say the one caveat is the travel period would probably only really be in the incidence where CRS is a concern. So it's generally the first month. So thereafter, I would say that these can be given in community settings after we go through the window of monitoring for CRS. So I think at least in the lymphoma world, the community sites can probably give the first couple of doses of epcoritamab and refer for the cycle 1 day 15 dose, or vice versa, have our stock glofitamab, and then the patient go back to the community as long as they have the drug on their formulary. That doesn't require the infrastructure, because that, in a sense, once that's taken care of, it's just like any other monoclonal antibody.
Yeah, I think it's the same for myeloma as well. And especially there have been some hybrid practices in and around New York City that are now having capabilities for giving bispecific antibodies. Predominantly, it used to be at academic centers. Teclistamab, talquetamab, all these were focused, but then now it's come, we have some of our practice partners who now have with an affiliation to the hospital that are now starting to offer teclistamab. Sometimes they would prefer us to oversee for the first cycle or two, but I think in the future, once the risk for CRS has abated, like Dr. Phillips was alluding to, I think it just can be given in the community as well.